Hello everyone, my name is Catherine. Today I'm going to present using amniotic autograft membrane and diabetic foot ulcers when it comes to wound care. One of the reasons why I picked this topic was because just with my past clinical experiences, it's almost guaranteed that there's at least one patient on the floor that is not only diabetic, but it has some type of diabetic foot ulcer that needs some type of wound care. So I thought that this would be a really good topic to look further into to see are there any other options to help with these patients with their chronic wounds and with their healing. So my clinical question, my PICO question is adults with diabetes age 18 to 65 years with foot ulcers, does the use of standard wound care compared to the use of an amniotic autograft membrane for wound care improve healing? If you don't know what an amniotic allograft membrane is, it's a type of graft made from amniotic fluid, made from the amniotic membrane that is filled with cytokines, and it can help with like growth factors to help improve wound healing. I did find some previous studies that they have used these on burns and found them to be quite effective, but the studies I'm looking into are specifically for diabetic foot ulcers. So this is a quite significant problem in the United States. Over 1 million of individuals with diabetes suffer from a non-healing diabetic foot ulcer. Complications include chronicity, reulceration, osteomyelitis, and amputation. It is quite costly in the United States with these complications, estimated about $17 billion. And then for a patient, the average 1 year medical cost estimate is about $28,000. So my process of research, I used two databases. I used the Ovid Nursing Database and the Cumulative Index of Nursing and Allied Health Literature. So the keywords I used were diabetic foot ulcers, standard wound care, amniotic autograft membrane, and nursing care. I excluded articles that were international and published before the year of 2017. My results were quite limited. From the Ovid Nursing Database, I only had 10 articles, but at least with the Cumulative Index of Nursing Allied Health Literature, I had 100 articles. I appraised about 10 articles, but I did find that 3 of them did answer my PICO question. So they're here summarized in my summary of evidence. So one was a meta-analysis, and the 2 were randomized controlled clinical trials. The findings that we found is that the amniotic autograft membrane does show a significant impact on wound healing. They found that patients who had the amniotic autograft membrane had better wound healing compared to just standard wound care, and also showed a reduction in ulcer and definite volume. However, there were some limitations with these studies. The Thompson et al. Only did a study on 13 patients just because of the strict criteria to be in the study. There's some lack of diversity. A lot of it was with white Caucasian men. And the criteria to be in part of these studies were very strict. For example, participants had to be free from infection, and if they had some type of infection with that wound, they were cut from the study. So with recommendation for practice, patients with diabetic foot ulcers should receive early referrals to a wound care team. This is just so that we can provide specific educational interventions such as wound care management, diabetes management, offloading, and early detection and prevention of complications. Because they did find with these studies, they think the reason why amniotic autograft membranes are so effective is because these patients had to be compliant during treatment. They had to go at least once a week for these assessment and wound care, and that's why they think that the amniotic autograft membrane was very effective with wound healing. So in conclusion, amniotic products do increase the rate of healing in diabetic foot ulcers compared to standard wound care. Patients treated with this product did show a higher frequency of wound closure. And they did find that patients and their families, they have to be educated on blood glucose management and prevention, especially after when the ulcer is healed. So as nurses, I do think we need to be patient advocates for these patients. They're immune compromised. They're not going to have the same type of wound healing compared to an average person. So I do think we need to look at other ways to help with these wound ulcers, just instead of just using standard wound care, because their body's not able to respond the same way as, let's say, someone who doesn't have diabetes. But I do think we need to do further studies with using this type of membrane, just because I would be curious to see, would it still be as effective on a wound that is infected? I would be curious to see, is it able to produce the same type of wound closure versus, if it's able to produce the same type of wound closure on an infected wound compared to one that's not infected. So that was my presentation, and I hope you enjoyed it. Thanks.